Zainab.
Dana, can you unmute? Oh, I think she's on mute now.
Sorry, I wanted to check. I cannot see any chat.
Yes, you cannot. Okay. Yes, you can start, Zainab.
Okay, I will start. I'll start over. Okay. Again, welcome to everyone. My name is Zainab Naimi. I work at the Department of Maternal, Newborn, Child, and Adolescent Health in WHO headquarters in Geneva. Before we start with the webinar, we have some house rules that are available at the top of the chat window. I will repeat these so everyone is reminded. Everyone's muted on entry, and we only unmute speakers. We will have a question and answer session after the presentation. So during the presentation, please post all your questions in the chat room and send them to all participants during the presentation. And if you don't have the option of sending it to all, then send it to all panelists. My colleague, Benedict Walter, will note down all the questions and read them out loud in the question and answer part of the webinar that she will be moderating. Any questions that we don't get time to answer today will be shared with our speaker and will be answered on the website in the following days. Moving ahead, as you know, the Network for Improving Quality of Care for Maternal, Newborn, and Child Health has been organizing a series of webinars on selected topics on quality of care, focusing on a country perspective and also on quality improvement implementation science. So far, we had 3 webinar series, starting with first, point of care quality improvement, followed by examples of quality improvement work from the network countries, and then the importance of WASH for delivering quality health services. Today, we have a special session to zoom in on the new WHO recommendations on intrapartum care for a positive childbirth experience. These will be very important to consider as countries move ahead with planning and implementing quality of care improvement roadmaps for maternal, newborn, and child health in the network countries. Our speaker today is Dr. Olufemi Oladapo. Femi is a maternal, perinatal, and public health expert working at the Department of Reproductive Health and Research, WHO Geneva, where he provides managerial and technical leadership in evidence synthesis, research, and guideline development to improve maternal, perinatal, and newborn health. Femi will give us an overview of the new recommendations on intrapartum care. He will focus on experience of care as a critical aspect of ensuring high-quality labor and childbirth care and improve women-centered outcomes, additional to provision of clinical care. I'm sure participants on the webinar have an interest in understanding how this links to the WHO standards for improving quality of maternal and newborn care in health facilities, which Femi will be able to address. As we move ahead to explore some of these themes, I give the floor to Femi to orient us on on these new recommendations. Femi, you can go ahead.
Thank you very much, Zainab, for your kind introduction. Can everybody hear me?
Yeah, we hear you well. Please, if you cannot hear, Femi, please type in the chat.
Okay. And you can see my slides as well.
Yeah. Yes.
Great. So, good morning, good afternoon, good evening, colleagues from everywhere around the world. It is my privilege to be with you today to share with you the new WHO recommendations on intrapartum care. First, I'd like to thank the Quality of Care Network for allowing us to use their platform for sharing the new recommendations. In the next 20 minutes or so, I will be summarizing the new WHO guidance with a specific focus on experience of care. The question that we're all kind of interested in, both the mothers and the health practitioners is, what's in a good birth? What makes birth a good experience, so to say? This is a question that one can answer in so many different ways. For instance, you could say a good birth is having a live baby and a live mother at the end of the birth, or having a birth without any kind of morbidity. But I think it's a bit more nuanced than that. And the answer to this question, or if I could say the answers to this question, can be found in the new WHO guidance. The guidance was published in February 2018. And for those of you that are familiar with the normative work from MCA and RHR Department of WHO, this is a follow-up to a similar guideline on antenatal care, titled Antenatal Care for a Positive Pregnancy Experience. So this is complementary to that and following the same theme. These two guidelines are quite special in the sense that they exemplify the WHO vision for quality of care through the pregnancy and childbirth continuum. And hopefully in the near future we'll have something similar for postnatal care. This is because they kind of both elevate the experience of care as a critical component of quality and not just something that is complementary to clinical care provision. As you all know, that the majority of women who undergo pregnancy and childbirth are normal, and they go through this experience without having any complications. So, the overall theme of the guideline, as it is, even as it pertains to clinical interventions, is experience of care, as I will elaborate on during the course of the presentation. Like any other guideline issued by WHO, this is quite comprehensive, based on very rigorous methodology. The sections on why WHO developed this guideline, the guideline development methods, the recommendations themselves as they span through the continuum of labor admission until the first stage of labor, and what are those things that we need to be able to implement these recommendations properly. Likewise, we present some evidence gaps that we found during the evidence synthesis in developing the recommendation. Our dissemination plans, including conferences, translations, and this kind of platform that we're using this afternoon. And how, what are those things that need to change within the health system to make these recommendations implementable, and our plans for updating the guideline. So, why did WHO choose to develop this guideline? I'm sure for many of you working in different agencies, there's always been some kind of guidance around intrapartum care, even from WHO. But we found this became quite necessary in the sense that there are many unresolved issues around intrapartum care. First, we all agree that over 100 million births occur every year, mostly in Asia and sub-Saharan Africa. But our focus in the past several decades have always been on ensuring maternal survival, even when we're certain that the majority of births occur in women who do not develop any complications for themselves or their babies. So one of the most important advances in recent years, as you all agree with me, is the expansion of global agendas beyond survival to also ensuring that both women and their babies could also thrive to achieve their full potential. So it's not just about improved well-being, but also achieving full potential for health and life. And this is the central piece of the main global agendas around maternal, newborn, and child health, talking about the global strategy for women's, children, and adolescent health, as well as the sustainable, the third goal of the 2030 Agenda for Sustainable Development, which is about ensuring healthy lives and promoting well-being for all at all ages. That is not to say that the time of birth is not critical in terms of survival for the mother, as well as the babies. For that small fraction of women or babies that develop complications, the risk of death, increases very sharply, and that's why investing in improving quality of care around the time of birth, as has been shown in the Lancet series in 2014, could yield triple return on investment. That's why this is quite critical. For those of you that have been following the WHO work in the last 3-4 years, I'm sure you're familiar with a framework on quality of care, where we sort of envision a world where every mother and newborn receives quality care throughout the continuum of pregnancy, childbirth, and the postnatal period. And very critical part of this framework is the experience of care. For someone like me coming from a clinical background, I think this is probably one of the greatest achievements of our time, which has been sort of ignored for years. So what this framework is saying is that the experience of care is part and parcel of quality of care, and if you're trying to improve quality, focus should not just be on provision of clinical care alone. So this is the kind of perspective that this guidance took to ensure that the recommendations not just address the clinical interventions, but also looking at the experience of care interventions, if you will. So, still talking about why this is critical for WHO. You will agree with me that compared to the 60s and 70s, pregnancy and childbirth have become increasingly treated as a disease condition that kind of need intervention. And in the last 2 to 3 decades, our focus has been on how to control the birthing process. How do we start labor artificially? How can we accelerate labor? Or how can we stop labor? And while there's a lot of clinical benefits to this, there's also significant harm that will occur. And these days, there's hardly does any woman undergo labor and childbirth without receiving any kind of obstetric intervention. So over-medicalization has become a serious issue. And studies have shown that increasing medicalization of birth tends to undermine women's own capability to give birth by themselves, and in essence, or subsequently, negatively impacting on their birth experience. And apart from some of the perceived interventions that practitioners apply during labor and childbirth, there are also some so-called obstetric rituals that remains persistent, like perineal shaving, using enema routinely, performing amniotomy even when there's no problem, giving IV fluid to every woman in the labor ward. These are some of the things that WHO have said in the past, but we think we thought we needed to re-emphasize them because they're still being practiced in several parts of the world. Another critical reason why there's been a lot of the over-medicalization of childbirth is our poor understanding of what normal labor really entails. And in the last decade or so, the tool that we're all very familiar with, which is the partograph, has come under intense scrutiny, if you will. And that's because there are newer studies showing that labor could actually be slower than previously thought. And also more importantly, the reference lines that we're very familiar with, the alert line, which is based on 1 centimeter per hour rule, and its corresponding action line, is becoming more and more challenged in the sense that substantial proportion of women could actually cross those lines, and that might not mean that they are abnormal. In support of this, kind of skepticism about the usefulness of the alert line as what you could call a good binary classifier, for births that could result in good and bad outcomes. WHO conducted a cohort study among 10,000 women in 2 sub-Saharan African countries in 2014-2015. And the findings shows that if you individually plot the labor profile of every woman that participated in the study, as shown by the video you're looking at, substantial proportion of these women actually cross both lines. And in this study, close to 49% of women actually cross the alert line. And you start to ask yourself, does this mean all these women are abnormal? But what we found that was even more interesting is that having adverse outcome is not necessarily related to the progression or the rate of cervical dilatation during labor. As you see in the subsequent graph, all the women with the red label profile are those with abnormal outcomes, and you could have abnormal outcomes both in the zone before the alert line, after the alert line, and even beyond the alert line. So, in a nutshell, this is not a good classifier. However, this is what we're using presently, and conclusion was that this was one of the reasons why we have a huge rates of augmentation of labor and unnecessary cesarean section nowadays. So, what exactly does the guideline entail? In terms of focus, well, the guideline focused on healthy pregnant women as well as adolescent girls who have no risk factors for themselves or their babies and who otherwise appear healthy, at least at the beginning of labor. However, in terms of experience of care, the guideline includes recommendations that should be provided to all women regardless of their risk profile. I wouldn't spend too much time on the methodology, but just to flag that as part of the scoping process to develop this guideline, we did something that is a bit unique that we don't normally do for our previous guidelines, except for the antenatal care guideline. We conducted a systematic review to understand what exactly mattered to women during childbirth. And that's because our overarching aim was to make recommendations that impact on what is important to women as well as their families. And what did we find? We found that most women, regardless of where they are around the world, want exactly the same thing. Most women want to give birth, have physiological birth with little or no intervention. They want to be healthy and they want their baby to be healthy after birth. They desire to be in control, to have a sense of control and be involved in clinical decision making that pertains to them. They want to be treated by sensitive, caring, kind, and respectful staff. And they want to be supported by a birth companion. So, in summary, the conclusion of that review is that women want a positive childbirth experience that fulfills or exceeds their prior personal or social-cultural beliefs and expectations. So what are the recommendations? I'm not going to go through all the recommendations. I'm just going to focus on those that are women-centered and those that are specifically addressing experience of care. But as I mentioned before, we had recommendations that spans through the first, second, third stage of labor, as well as supportive care that a woman should receive through labor. So in total, there are 56 recommendations. There were 26 brand new recommendations, but we also incorporated existing recommendations that fit into the context of positive childbirth experience. And for every recommendation, there is additional remarks that will help the reader understand why the recommendations were made and how can they apply it properly in practice. So the first recommendation that deals with experience of care has to do with respectful maternity care. And you might wonder that, oh, this is a no-brainer. We felt that some of these issues around experience of care have been neglected for decades. And even though they might look like a no-brainer, we choose to go in this direction because we felt that having them as a guiding principle or having them as a footnote or remark can get them lost in translation. So we have a recommendation on respectful maternity care that says that RMC, which refers to care organized for and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support through labor and childbirth, is recommended. And for this one, we made it very crystal clear that all women in this regard is everyone, regardless of their risk status at the beginning or during labor, whether they're giving birth at home and in the hospital, whether they're being managed by doctors or midwives or non-doctors, and regardless of the country income level. And this is in agreement with the United Nations Human Rights Council, in accordance with the human rights-based approach to reducing maternal mortality and morbidity. One thing that's always been a challenge in terms of ensuring that this is done properly is that people sometimes forget that the providers also need to have a respectful and dignified working environment. So we also made that very clear in the remarks that interventions that one is trying to use to encourage a policy of respectful maternity care should also include that enhance a dignified working environment for healthcare providers. Likewise, effective communication. Communication is often taken for granted. However, for this guideline, the panel recommends effective communication that is simple enough, that is culturally acceptable, using methods that the population understands as its recommendation. And in the absence of a universal definition of what one could regard as effective communication in the literature, the guideline panel defined a set of minimum criteria as what is expected to practice in the labor ward. And this deals with introduction of the woman, introduction of the healthcare provider to the woman, and ensuring that the woman is addressed by her name, avoiding the use of medical jargons, using aids as necessary for the woman to understand what is happening to her, and responding to the woman's needs and preferences, preferably during pregnancy and not just at the time of labor, so that these things can be known ahead and planned for ahead of labor and delivery. And very importantly, getting consent, verbal consent, or where appropriate, written informed consent, especially for pelvic examination and procedures that are performed for the woman. And this is something that we health professionals tend to take for granted. The next one has to do with companion of choice. I think this is not a new recommendation. We have it in two previous guidelines, but we felt it's very relevant to intrapartum care for a positive childbirth experience, and we decided to bring it back into this one. We also make it very clear that a companion in this sense is anyone that the woman chooses. It could be a spouse, a partner, a friend, or a relative, a community member, or a doula. But what the guideline panel also made very clear is that we need to respect the woman's wishes, and a companion should not be forced on the woman. There are some women who do not want to have any companion whatsoever, and that their wishes should be respected as well. Then we have some recommendations that sort of define what you can call women-centered definitions and duration of the phases of labor. This is something that we don't traditionally do, but we felt that because of the lack of universal guidance on what is meant by latent first stage and active first stage, the guideline panel issued a recommendation on this based on rigorous evidence. So what is new about this is that the end of the latent phase of labor is starting from 5 centimeters for both nulliparous and multiparous women. Likewise, in terms of how long it takes, the panel was not too rigid in terms of defining a set time for this. And the way this is described is that women should be informed that the standard duration has not been established and it could vary from one woman to another. So this is moving away from the 8 hours that we were using before with the previous, the very early design of the pathograph. To something that is a bit more reflective of the woman's individualized progress. Likewise for active phase of labor, so a latent phase ends at 5 centimeters, active phase also starts at 5 centimeters. And in terms of duration, the panel was also not very rigid because the evidence is a bit fluid in terms of how long active labor should last. So for nulliparous women, it's saying it shouldn't extend beyond 12 hours, and for multiparous, it shouldn't extend beyond 10 hours. In terms of progress of labor, there's a recommendation around the alert line that we're all very familiar with in the pathograph, and the panel chose not to recommend the use of the alert line as it's been found to be inaccurate for identifying women that are at risk of adverse outcomes, and therefore it should not be used for this purpose. Likewise, the panel recommends that interventions should not be based on the fact that a woman is just less than 1 centimeter per hour in terms of cervical dilatation, as this rate is unrealistically fast for some women. So in a way, this recognizes that everybody is unique, and women care should be individualized to the extent possible. In terms of assessment of fetal well-being, I'm still talking about low intervention approach to labor care. Routine cardiotocography is not recommended for assessment, fetal well-being assessment in women who are apparently healthy. And you might ask why. I think one of the major reasons, apart from the fact that the evidence is not supportive of the use of routine cardiotocography, the panel also found that using this kind of device does not give women the choice of moving around in labor and sort of prevents them from having the bad position of their choice. Likewise, pain relief is very critical to ensuring a positive childbirth experience. There are 2 recommendations relating to non-pharmacological interventions around relaxation and massage technique, and there are 2 pharmacological interventions around epidural analgesia and parenteral opioid. For second stage, I think the recommendation that is critical here has to do with the timing, similar to the definition of the duration for active first stage. they're not being very rigid, saying that it usually should be completed within 3 hours for nulliparous women and 2 hours for parous women. We all know that usually, between half an hour for priming and for within 15 minutes for multi, the second stage is usually over. However, evidence shows that if everything is progressing normally, there shouldn't be any reason for concern with the woman is still within this time limit. And in terms of birth positions, we're giving the woman the choice of birth positions that she feels most comfortable with. And this could be a sitting position or squatting position, but not the standard lithotomy position that we practice for ages. We feel the evidence does not support that position is better than the other positions. But while we're doing that, we should also take care to ensure safety for the mother and the baby. The other thing that we feel is also very women-centered is that women should be given, in second stage, follow their own urge to push, rather than being directed to push as we do in several of our labor wards. Episiotomy is, the rate is quite high in many settings, including Europe and Latin America. And despite the recommendations that have been around for years, the practice is still not being tamed as it should be. So one of the other recommendations is to have a policy of no episiotomy if possible, but rather we will should have a policy. Or rather, a policy of routine or liberal episiotomy is not recommended. Manual fundal pressure is something that's also practiced, which is quite barbaric. If you look at it, it's not only dangerous to the woman, but is also associated with a negative bad experience. So this is also not recommended. For the newborn, we recommend skin to skin contact to encourage promote breastfeeding, prevent hypothermia, and also very importantly, encourage mother and neonatal bonding. Likewise, putting the baby to breast as soon as the baby is clinically stable is another recommendation that we pulled from existing newborn clinical guidelines. And for the women after birth, use of unnecessary interventions like routine antibiotics when the vaginal birth is totally uncomplicated is not recommended. And use of antibiotics for episiotomy as well is not recommended. So in terms of how we envisage this to be rolled out, we are looking at a situation where the various interventions that have been recommended can be used as a package of care in a way that they facilitate the woman's own capability to give birth on her own. And we're introducing a WHO intrapartum care model, which should be possible to be implemented regardless of the setting, regardless of the cadre of staff, or how care is organized in any setting around the world. In terms of dissemination, we've used different kinds of platforms, done a press release, and that's available on our website. There are infographics on Twitter. There are conferences lined up, FIGO, ICM, and the likes. And in terms of implementation too, we're working on updating the current design of the pathograph in a way that it could facilitate the practice to ensure that women have a positive childbirth experience after birth. For monitoring and evaluation, I will just refer you to the WHO publication on standards for improving quality of maternal and newborn care in health facilities, where we have the outcome input, output, and outcome measures as you can customize to whatever setting you find yourself. Just before I finish, the guideline development went on for 2 years. Many people participated, over 50 people participated in developing the guidelines. I just want to acknowledge my colleagues both within WHO and outside WHO that participated in the guideline development, as well as our funders, USAID and WHO HRP. For further information, you can either contact me or my colleagues. You can find the details in the published guideline, which is available on our website. So that's my last slide. Thank you very much for listening.
Thank you so much, Femi. That was extremely informative, and you've only been through some of the recommendations out of the 50-something, focusing on the experience of care. You've got quite a few questions coming in, so let me start with the first one. Please pose your question to all panelists, not to the host, because otherwise only Zainab sees them. So pose them to all panelists. The first question is from Susanna Koo, asking you how this recommendation will affect hospital policies and whether you have any suggestion or previous experience to change hospital policies to support this recommendation.
Sorry, can you come again, please?
Yes, sorry. You have a question from Susanna Koo asking how this recommendation would affect hospital policies, and if you have any suggestion or previous experience on how to change hospital policies to support this.
Okay. Can I get all the questions and then I can...
No, you have a lot. They are long.
Shall I respond as you asked them?
Yes, please, because if we have too many, we will have to enter them back in writing later.
Okay. Thanks very much, Susan, for the question. I think the way we've done this, what we've done is to issue a global high-level recommendations. And we expect individual countries, through their Ministry of Health and professional organizations, to adapt and adopt the recommendations that we have developed. And I think from national clinical policies or national guidance should the individual hospitals tap from, because the task for the ministry is to contextualize the recommendations in a way that it's going to make it doable within the context of the hospitals there in the countries. So right now we started something with South Africa. Interestingly, the Medical Research Council in South Africa is currently reviewing their intrapartum care guideline, and the release of a guideline was quite timely. So we were invited to participate in their meeting, and there are certain things where they feel that contextually some of the recommendations are currently impossible, and they wanted to get our guidance, which we provided. And that is going through some iterative phase at the moment, and that once it's finalized, they will be shared across the hospitals in South Africa for implementation.
Thank you. Thank you, Femi. More questions. So you have another question from Natalie Bruce asking you if you have any thoughts around how to measure the reduction in the over-medicalization of children's care, or childbirth care, sorry. And do you have any way to measure the reduction in over-medicalizing childbirth? And how do you know if these recommendations are going to be followed?
Okay.
If you say the worry is that we tend to focus more on monitoring than on monitoring of outcomes.
Okay. Good question. In terms of how do we know, whether the recommendations are being implemented. Because we're looking at 56 recommendations, the idea, it's practically impossible to follow up all the outcome measures for that ties or that corresponds to every recommendation. So, in terms of looking at what we're trying to address, we have a number of recommendations that speaks directly to the concept of positive childbirth experience, and I think those are the things that we would aim to measure. So, out of the list of 56, the slide that I showed on the intrapartum care model, just trying to find it, has some, what you could call highlight of the recommendation around, pain relief strategies, effective communication, companionship during labor, mobility, and continuity of care. So, I mean, the idea is not to try and measure everything, but to measure first what is doable within the various contexts, either at the country level as well as at the individual hospital levels. And in terms of measuring whether over-medicalization is reducing, I think, a certain point, or what you could call the main issue that we're concerned about in terms of medicalization is actually augmentation of labor and cesarean section. So having a baseline rate, depending on where you are, using those as the set point could be important as if you like, the main indicators to suggest whether medicalization is coming down. I know that in Europe there is a perinatal health report every 2 years or thereabout, where these major interventions during pregnancy are recorded, and by country, and things like episiotomy, C-section, augmentation are well documented. And the last one, even for some countries, their episiotomy rate as high as 72% or thereabout. So over time, with clear implementation plan of the guideline, countries or hospitals should be able to tell whether those rates are going down or whether they are going up.
Okay, you have a practical question from Alicia Carbonell, asking you about your use of photographs using the alert line. How do you recommend to deal with this? Because this is a new recommendation. So how do you recommend to implement that change?
Sorry, I don't get the question.
Sorry, she wanted to, in your presentation you explained that the alert line is not necessarily useful during monitoring labor. So she asked you, so now what? What do we do with this recommendation? And how do you implement this change? What do you use instead?
Okay, good question. So the main concern we have now is that the alert line is in part responsible for the over-medicalization that we're seeing. And there are studies that actually show that even before the line is crossed, the rate of using oxytocin is quite substantial. And when it's crossed, people really don't follow the guidelines that should ideally accompany the use of the photograph. So, to the extent possible, we are recommending individualized care for women. We have given a kind of boundaries in terms of timeline, from 5 centimeters to full dilatation. For nulliparous women as 12 hours, And as long as there is progress in labor in terms of cervical dilatation and descent, and as long as the fetal and maternal well-being is not in question, there should be no intervention. As I mentioned, we are revising the current design of the partograph, and one of the things that we are putting on that partograph is a kind of time lag per centimeter of dilatation. So rather than have a straight line, which sort of makes one size fits all, and for everybody that has managed labor before, labor could be slow at some point, and then the pace could increase at some other point. So there is a lag time that's associated with each cervical dilatation, during which if there is progression in labor, no matter regardless of how slow, and the fetal and maternal well-being is not in question, then labor should be allowed to progress. And we're taking this new tool through several phases of development, having user feedback, piloting, having international consultation, pilot testing, to ensure that we get this right. However, if one is working in a peripheral hospital where access to C-section or access to labor augmentation is not available or impractical, then in the remarks of that recommendation, the panel still says that their lab line could be used as a triaging reference line for identifying women that should be sent to or referred to a higher level of care.
Okay, I think we have time for 3 more questions. You have quite a lot more, but we're going to take 3 more. One is a comment actually from Vijay Kumar, asking you what you think about the fact that, okay, this recommendation focus on childbirth, but childbirth is a continuum from the pregnancy to 42 days after childbirth, and the positive experience should be really looked at throughout. So what do you think of that?
Okay, that's a good question. As I mentioned in my presentation, we have a similar guideline for antenatal care, and the methodology, the scope in terms of the population is very similar to what we have for this guideline. So now you could say that we have recommendations across pregnancy and childbirth for a positive pregnancy and childbirth experience, respectively. And we're in the process of doing something similar for postnatal period. So I agree that it's quite important, but we're not leaving anything out in that perspective.
Yeah, you have another question from Greggy the Cock, asking you how these guidelines relate to the quality of care guideline from 2016 for maternal and newborn health that WHO had published, the standard for quality of care for maternal and newborn health. And is the guideline you present is just a more detailed set of recommendations? I think you can clarify this, Femi.
Sure. First, the WHO publication on quality of care standards are not recommendations. They are standards, and they are aspirational in nature for every hospital or every health system to strive to achieve. However, to achieve those standards, you need clear recommendations about what to do. So this guidance is actually complementary to that, and in part the work on the standards also informed the scope in terms of the length and breadth of what we needed to cover in these guidelines. So, one doesn't supersede the other, but they are complementary to each other. And, many of the recommendations, in fact, one of the reasons why we were making recommendations on the experience of care is because we already have standards of care relating to those components. So, in a nutshell, they're just complementary to one another.
On the set of guidelines and standards and recommendations, there's a follow-up question from Brady the Cook on this. Does WHO also provide recommendations and resources to ensure that health workers are motivated, competent, and kind?
Is that a question?
It's a question, yes.
Oh, sorry, I didn't
and
get
kind.
I thought you were adding to what I said.
No.
Please ask the question.
Are there also recommendations on the attitude actually of the health worker to ensure that they're kind, motivated, and competent?
Oh.
Yeah.
Recommendation on attitude and that. There's no specific recommendation in that line. However, the recommendation on respectful maternity care, I think, encompasses that as well. If you read carefully between the lines and in the remarks section, that is what RMC is all about. So it's hard to make recommendation on attitude of people or health professional for women, as the case may be. But we could make recommendation on policy that engenders that kind of idea. I don't know if I've answered the question appropriately, but we have no specific recommendation.
Another side to that question that comes from Caitlin Williams, who is asking about the support, the need for respectful environment for the providers and the kind of support they need to have to be able to provide a good birthing experience. And if there is any recommendation that should be looking into this, so to address some of the barrier for health providers to be able to actually provide the right environment, the respectful and caring environment for women who are giving birth.
So if you recall, on the slide for RMC, I mentioned that in the remarks section we were also very clear about the fact that a dignified and environment should also be provided for the healthcare providers if we expect RMC to be well implemented and integrated into the health system. So we are not going to issue a specific recommendation for that. However, at the country level, the Ministry of Health level, there are ways that this can be adapted or made much more granular in terms of implementation. And I would also suggest that for anyone interested, it would be good to check out implementation considerations relating to specific recommendations in the guideline. It's of the, I think, Annex 4 or so of the guideline, where we sort of spell out things that need to be in place for the recommendations to be implementable.
Thank you so much, Sami. I will give the floor again to Zainab. Thank you so much. You have a lot more questions that came up, so I'm gonna send this to Sami right now, and he has agreed to answer them in writing. And the presentation, the recording, the question and answer, we will post it on qualityofcarenetwork.org/webinars. Zainab, over to you.
Thank you, Benna. Thank you, Femi, for guiding us through these new recommendations. I really actually feel that we need more time to continue this discussion, especially on the implications for different country contexts, what this would mean for the different levels of the system, from national level to actual application at facility level. So perhaps we need to consider a follow-up webinar So that's something for the group to consider. And I think also some questions came around the monitoring, and that would also require further discussion and to understand to what extent the recommendations are being implemented and follow up on that. So thank you very much, Femi, for taking the time. Thank you to all the participants for your questions. As Benna mentioned, the ones that were not answered will be answered online in the following days. And thank you, Benna, for the excellent moderation. As usual, I would like to remind you that recordings for all webinars are online, also the previous one on the Quality of Care website. We are working on updating the webinar schedule, so you would have the new list of series, and that will be posted when ready. And then finally, please do share these webinars with your colleagues that are interested in quality of care improvement work, and also the work that is happening in all the 10 network countries around implementation. Thank you to all of you, and see you next time.
Thank you, bye.